Let's do some voiceover for this case. It has to be released today. So this was in a case of extraction of the lower right 7. The tooth is already broken down as you see in the OPG. We begin with moisturizing the lips, always the first step, because we don't want any injured commissures. So after that, I begin with drying the area with a gauze pad, and then I'm applying some topical gel. That's actually a very huge amount, but that's okay. And then once the gel sits there and it numbs the superficial tissue, we begin with giving the patient block. Actually, giving a block here was not a very good idea, and I should have considered giving Gaugates instead to block from mandibular nerve because patient had inflammation. She was not getting numb after even giving this block. When I am poking the gums then afterwards, she was not numb yet. So that's how I felt I should have given Gaugates from the very beginning. I should have decided on that. But anyways, we gave LA, we gave block, now mandible, and then we are giving buccal nerve block. Now when I'm poking the nerves, the gums, she was feeling pain, not pressure. So we ask the patient if you're feeling pain or if you're feeling pressure. You should define what is pain and what is pressure. They will have the pressure, feeling of pressure because of the proprioceptive nerves, but they should not feel any pain. In this patient, she was feeling pain actually. So that's when how I decided to give her a Gaugates to block the nerve far away from the site of inflammation. And for Gauge, it's actually not very technique sensitive, and the success rates are much higher than the conventional block. So you place the long needle below the mesiopalatal cusp of the second molar, and you palpate the bone actually first by telling the patient to open wide as much as she can. So you palpate the anterior border of the ramus, and you take the needle, move it forward until you hit the bone, you hit the neck of the mandible, and then you release uh, the LA. And then, so what I'm doing here, I'm keeping the patient's mouth open because I want that nerve, that ramus, to hold the anterior position. If I tell the patient to bite ASAP, what will happen? The nerve will take a posterior position and the anesthetic solution will remain in the anterior position. So we don't want that. And now when I'm poking the gums, the patient is completely pain-free, so we are safe to go. So I begin with a straight elevator always, but before taking my elevator, uh, I always place a gauze pad to save the tongue, especially in the lower jaw, and also like it gives me some kind of support. So, uh, yeah, and now I took my straight elevator, place it in the interdental area, supporting the adjacent tooth, number 6. So here I'm using loops, my loops from Admetic, the 5 times magnification, and it's super comfortable extracting while you are seated and under proper magnification. So yeah, the root is almost out. Very controlled forces, not too much. You have to be very slow, do not rush it, and try to keep the forces as much controlled as you can. You should know what the elevator is doing, what it is elevating actually. It should not hurt the adjacent tooth, okay? It should not break the adjacent tooth, especially when you have, in cases when you have crowns. In the adjacent teeth, it's very, very important to make sure the crown is not displaced, and you should inform the patient before extracting that there are chances of that as well. But you should try to keep yourself in the safest position, and that you can do only when you are doing it with controlled forces, with forces where you know where these forces are going actually. So always try to be slow and do not rush it. So the mesial root is all out. The mesial root is out now, and we are left with the distal one, and it's also mobile but stuck in the bone at some point. So here, to make it super easy and super fast, what I'm doing, I will dry the area first for better visualization. It's a must for extractions. You do not want a field full of blood where you cannot see where the root is and where should you place your instrument. So what I'm doing here, I took my triangular elevator, the distal triangular elevator, and it's out in minutes, in seconds. You see? Yeah, we are done. Now what I'm doing, it's the most important part of the extraction, especially in cases where there is infection around the roots. So this patient, if at any point in the future she decides for implants, it has to be a very sound bone, a very well healed bone, without any more granulation tissue. So we want to make sure of that, and for that I'll have to remove the granulation tissue stuck deep down into the bone with this tweezer. I'm just removing the superficial granulation tissue that's attached to the gums, and then for cleaning deep down areas, I took my curate and I am cleaning it. I'm curetaging as much as I can to make sure there is no more granulation tissue coming out, and we are left with sound bone for better healing and for implant success in the future. So we are doing curettage, 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 and then after that I will be irrigating the socket with some saline, still some more curettage. Now what I'm doing, I'm irrigating the socket with some saline after making sure there's no granulation tissue left, and some alveoloplasty to make the healing faster. No stitches needed so far, and patient was doing good when I saw her on follow-ups. I'm placing the gauze pad dampened with some saline, and I tell the patient to bite on that for at least half an hour, give her post surgical instructions, and that's it. Thank you for watching.